my earlier slot, so thank you for allowing me to insert myself here. And I really want to give special thanks to Holly Atkinson and Susanna Sirkin, who, as I need not tell anyone on the phone, are just giants in the human rights field. And it was Holly more years ago than either she or I would care to admit who got me involved in PHR, and I owe her a deep debt of gratitude. But it has been a real honor for me to have had the chance to work both with Holly and with Susanna. And so I'm delighted for their giving me this opportunity. And I was really impressed with the conversation that you just had with Janine. It's always wonderful for me to hear the thoughtful, insightful questions and the answer and the exchange. And I was really deeply moved by that. And one of the things that really struck me was the challenge that a number of you spoke to about how difficult it can seem to have to be not necessarily a lone voice, but a part of a small group of people who are standing tall for the cause of human rights. And I just wanted you to know that we are acutely aware of that. And I am always reminded of Margaret Mead's observation that we should never doubt that a small group of thoughtful, committed citizens can change the world. And indeed, it's the only thing that ever has. We are reminded of that daily in the work that we do at PHR. So we are a small group of people, but when you are on the side of human rights, when you are on the side of justice, ultimately that moral arc of the universe does bend in your direction. And so we know this is difficult. But I wanted to, in addition to thanking you for being a part of this, I wanted to make a very simple point. By virtue of your medical training, each of you is possessed of an incredible superpower. And you have married that superpower with a passion and with a belief in justice and a belief in human rights that gives you an unbelievable opportunity to make a very positive dent in the universe. And I want you never to forget that you are possessed of that superpower. Janine spoke about using her power as a gifted and thoughtful and observant writer, as a journalist, to make a difference. That is a gift. Your gift is science. Your gift is medicine. Your gift is the passionate gift of healthful healing. And you have an opportunity to bring that to bear in the world. And it is a big task. And we live in a difficult and challenging time where we have to wrestle daily with disasters that are both natural and man-made. And Janine referenced back into the Torah, also from the tradition of Judaism, is the observation that you're not obligated to complete the work, but neither are you free to abandon it. And implicit in that is the recognition over centuries, over millennia, that the work of human rights, that the work of justice is daunting, is large, is challenging, and requires constant work. I often say that our job at PHR is to put ourselves out of a job, knowing that the work will always be there to continue, and that we must do it. Susanna knows that this is my favorite part of my role as a chairman of the board of PHR, because frankly, seeing each of you, hearing each of you, feeling the passion, the intensity of your focus on human rights and on justice gives me hope, and it gives all of us hope. You are the future. We hope you will join us directly. We would love for you to be, formally part of the broader PHR organization. We are doing great work, and so we hope that work will continue long past your days of medical studies, and I'm confident that it will. So again, thank you for the work that you do. Be mindful of the superpower that you are uniquely possessed of, and keep doing this wonderful and good work for justice and for human rights. It is you who give us hope for the future. Thank you.
Thank you so much, Alan, for that very inspiring call to action. We always love hearing from you. And now I'm going to pass the torch to someone we're very lucky to have today, who's just going to talk a little bit about his work, about himself, and about his experience addressing, engaging in social justice issues as a practicing, not only as a practicing physician, but as an American transplant surgeon. So we have Dr. Francisco Cigarroa. and I hope I said that correctly, so please correct me if I didn't. And he has served as Chancellor of the University of Texas System. Um, and I'm just going to pass it on to you, and you can talk about yourself. Thank you for joining us.
Well, thank you, Sebastian. And Alan, it certainly is nice to meet you and to meet, all these wonderful, students before us. So Sebastian, I thought in the short time period that we have together, I can comment a little bit about how, as Alan stated, that as individuals involved in medicine um, and in the health professions, probably are in the best position to be able to not only care for patients and give patients and their families hope, but also we're in a position, because we see patients from all walks of life, an opportunity to be involved in very important social justice issues. And that can be done at the local level. It can be done in your community, state, nationally, or even globally, because of the work that we do. In my case, I would say that my background influenced me a lot, towards my passion in, making certain that, there is social justice and that every human being could be positioned to achieve, their greatest, inherent human potential. And I grew up in Laredo, Texas, which is literally on the Texas-Mexico border region. I grew up at a time where, despite there being a bridge across two nations, that it was really a seamless bridge. It was really, people would walk back and forth, without any anxiety, any hesitation between, Laredo and Nuevo Laredo, Mexico. And you really, got to learn, the beauty of two cultures, both in language, in music, and in values. I'm a third generation physician. And, my father basically practiced medicine in Laredo from 1947 until his death last year, and was working until a week before he died. And so through his eyes, I was able to see how a community actually, really, really benefited from not only him being a physician, but his involvement in social justice, specifically in education. I got to see him at a very young age, maybe at the age of 5 or 6. Every Friday evening we would make house calls, because in the 1960s, 70s, and a lot of people just couldn't get to the clinics or to the hospital. So, Dad would do house calls every evening, but it was a great way for his children to spend some time with him on a Friday evening. And there were 10 of us. And so we got to see firsthand, really the beautiful individuals and the great values that the most impoverished, had in Laredo, Texas. They were living in colonias. And so you really got to realize the beauty of all people, no matter their background, their ethnicity, or their, socioeconomic situation. So, Dad actually inculcated in us, the importance of education, and that through that, any one of us could achieve our fullest potential. So he taught us to take risk, as long as, the risk was, for the right reasons. And, he and Mother inculcated, the fact that we should try to get educated in the best possible way. And so my risk was actually leaving the state of Texas and actually going to Yale. That was the most difficult transition I've ever made, not because I was homesick or anything. It was just that I was so underprepared. I went to school in the poorest public school system in America at the time. But I think I learned, the values of perseverance and tenacity. But the beauty of actually, going to Yale was that I met people from all over the world, right? Individuals who, can actually help you advance excellence through, areas that you thought were important. I didn't think I was going to get into medical school because my first 2 years were pretty bad, but I did excel my last 2 years. And I got into Southwestern Medical School in Dallas, and I met an individual there by the name of Michael Brown. And Michael Brown was actually my professor of medicine, internal medicine, and he actually encouraged me to pursue a career in academic medicine. I had no idea what that was. But Michael Brown actually believed in me and wrote my letter of recommendation to MGH. And I remember going back to him when I got accepted, and his words were, "Don't disappoint me," because he wrote my letter of recommendation, and he wanted to make sure that I lived up to his letter of recommendation. But Michael Brown actually also taught me that you can't rest on your laurels. You've got to continue to be the best you can. And Michael Brown eventually got the Nobel laureate for hypercholesterolemia. So ended up doing a fellowship in pediatric surgery and then transplants, and was going to stay at Johns Hopkins Hospital. But ultimately, my wife said, life is a balance, and it's important for our children to, know their grandparents and all their cousins and become bilingual. And so I ended up coming to San Antonio, Texas, not knowing what this would be like. People thought I would be committing academic suicide because at that time, San Antonio, from an academic perspective, was really not, at the orbit of other academic health centers. But what happened was an amazing thing. I was actually on call one day, and a lady came in fulminant failure, liver failure, ended up doing a liver and a kidney transplant on her. And it so happened to be that as I got to know her, she actually worked for my parents. Early on, there were 10 of us, and she would help raise us a little bit. And in fact, she changed my diapers. And ultimately, I was in a position where I was able to save her life by doing a transplant on her. And it just showed me how important it was to be able to provide the best care to a medically underserved region. So in San Antonio, I also learned that I certainly was comparing San Antonio with like Hopkins and MGH. And, I was doing some complaining and some whining and quickly realized that didn't get you anywhere. And, actually became, a problem solver. And so that ultimately, for whatever reason, got recognized. And the Board of Regents, asked me to become president of the Health Science Center at a very young age, like 5 years out of my fellowship. It was absolutely insane. But I remember going back to Michael Brown and asking him, is this something that I should do? Because, I'm a surgeon, I love taking care of patients, and this is administration. I never thought I would want to do that. And Michael Brown actually said that, in that position, Francisco, you can really get involved with population health, really get involved in addressing healthcare inequities. And, I think you should do it. So, again, an old mentor came back and gave me the courage to pursue it. What I realized then, and again, going back to growing up on the Texas-Mexico border region, is that there were two universities at, there are 15 universities in the University of Texas system. And there were two universities in South Texas, which is really kind of the poorest part of Texas practically, that has been medically underserved. And these two universities were not eligible for funds called permanent university funds. Permanent university funds are the funds that the University of Texas system gets as a result of all the oil and gas revenue that University of Texas owns in West Texas. And I could never understand why the two universities on the Texas-Mexico border region that, were also the most socioeconomically disadvantaged area of the state did not get money from the oil and gas revenues like the other 13 UT universities. I thought that was a huge injustice. And I learned that the reason for that was that because these two universities were originally acquired as community colleges, that the state constitution did not allow them to be eligible for these funds. And yet I would see these students, I would see these presidents, and I thought it was, how could they be part of the UT family? Well, ultimately, I ended up becoming chancellor UT, and now I was in a position where I could actually influence, legislation. And in my mind, I always had this issue of inequality. Well, what I learned is that if you actually, there were a couple of reasons, but one of the issues that ended up developing was that one of the universities ended up becoming, financially very, very compromised. And in fact, there was a risk that it was going to be closed. And this was a university that was a Hispanic serving university and, had 90% Hispanics. And so the only way to salvage it was that they can get permanent university funds, these precious oil and gas revenues. But we were against this constitutional issue. Well, what I realized is that if you merged these two universities together, they were only about 30 miles apart. And at the time we were creating a medical school, if we put together these two universities in medical school, in fact, we were creating a new university. And because of that, we were able to get around this constitutional issue. And for the very first time in the history of their existence, they were able to get permanent university funds. And in that first year, they got an additional $300 million. And now they've got a medical school. And now they are among one of the largest Hispanic serving institutions in the United States. And they probably graduate more students with Pell Grants than any other university, certainly in this part of our nation. And it's been nothing short, of a transformational experience for that region. So what I'm saying is that opportunities are going to come up before you that because of your interest in social justice, you will be in a position to be able to do something about it if you stay tenacious and if you just give it, some additional thought. Now, after about 15 years of administration, I came back to become a transplant surgeon again. That was pretty scary because, 15 years of not actually being in the OR every day, it was pretty terrifying to actually, do some of the most complicated operative procedures, after being in administration. But fortunately, I had good mentors. And now I'm the director of the Transplant Center here in Texas. And one of the things that I'm working on now is that there are healthcare disparities in the area of transplantation. For example, patients who live in a geographically distant site from a transplant center or have multiple comorbidities like diabetes, hypertension, heart disease, et cetera. Transplant centers are a little shy about doing those transplants because, their existence in regards to outcome data, insurance centers of excellence, are all based on 1 year survivals. And that 1 year survival is a 95% 1 year survival, which I think is a bit ridiculous in the sense that you're taking care of some of the sickest patients ever. And so what that results is in risk adversity because why? Most of the patients that we care for in that circumstance are going to be Hispanic, are going to be African American, are going to be socioeconomically disadvantaged because those, that population often has, mental health issues because of anxiety, stress, depression. They have comorbidities such as hypertension and diabetes. But there are ways around that through telehealth, through teleconferencing, through developing geographical sites, clinics. And so, what I'm saying is that because of the work that we do, we see where the healthcare inequalities are, and you as individuals can do something about it. So I think you all are in a great position to advance human rights, to really do our part in mitigating healthcare inequalities, and be courageous. One person can make a huge difference. And if you develop wonderful partnerships in your journey to eliminate inequalities, it'll be even more powerful. And it'll be extremely joyful and satisfying. So I hope that, my little kind of life experiences in about a 10 or 15 minute overview has been helpful to you, but I'd be happy to answer any questions that you might have.
Thank you, Dr. Cigarroa. I think we might have just enough time for like one question. So if anybody has a question, please go ahead and ask.
Hi, Dr. Cigarroa. I just had one question. You mentioned that you were interested in tackling the inequities in transplant surgery. I was wondering if regenerative medicine was very present in transplant surgery, and if you had any experience attacking those type of disparities in terms of getting access to those type of therapies.
Well, regenerative medicine will certainly eventually, allow us hopefully to create, kidney allografts and liver allografts, heart allografts. And so therefore, the whole, supply of organs versus demand for organs will be better balanced. I think that's still years away. One of the things that we've done is actually develop what we call as a center for life, where we actually the organ procurement organization transfers patients from small community hospitals here, such that we can honor the wishes of that individual and their family, which is really to be able to procure their organs. These are brain dead, individuals who are at small community hospitals. There are a lot of individuals who want to donate who are brain dead, who are at small community hospitals that just can't do it because, the hospital doesn't have the capacity to be able to proceed with those donors' wishes. And so what we've seen is that, we've been able to actually continue to do very well and be able to honor the wishes of the individual and their families to procure organs through the Center for Life during the pandemic. Number two is what it's also opening up is a whole new field of organ preservation research. That is, how can we actually convert a marginal donor organ, that is a marginal donor liver, let's say, for example, a fatty liver, of which Hispanics, have a lot of metabolic syndrome and result in NASH. If we can actually, through ex vivo warm perfusion of the liver and provide, medical therapeutics on the pump, can we actually deplete this liver of these fat globules and regenerate the hepatocytes over a day or two that actually converts that marginal donor into an optimal donor? So that's another way of addressing, the supply-demand inequality in regards to those who need transplants. So, there are a lot of things that we can do to kind of eliminate that imbalance.
All right. Thank you so much, Dr. Cigarroa. I'm sorry that we couldn't have more time for you, but we're so thankful that you joined us for this time and shared about your life story and about how you've been involved in social justice. And thank you, Mike, for asking that question as well.
Well, listen, have a great time. Have a beautiful weekend. And Sebastian, thanks for inviting.
Thank you so much. Take care.
Bye-bye.
Have a good day. Okay. I'd like to invite Jackie to introduce Dr. Wendy Dean, who's been here since the morning and who's going to now focus the moral injury conversation on moral injury in medicine and healthcare. Jackie, you can go ahead and introduce. Okay, or I could do that. Once I think, oh, she's here. She's here.
Hi, everybody. Sorry for the delay, but it is my absolute pleasure to introduce Dr. Wendy Dean. Thank you so much for waiting, Dr. Dean. I know we're running a little bit over time, but we really appreciate you staying here with us today and showing up early. So Dr. Wendy Dean, she practiced for 15 years as an emergency room physician, and then as a psychiatrist. She left clinical medicine when generating revenue crowded out the patient-centered priorities of her practice. Dr. Dean then spent 8 years in numerous leadership positions overseeing medical research funding for the US Army, and then as a senior executive at a large nonprofit in Washington, DC. She supported novel strategies to restore form, function, and appearance to ill and injured service members. In 2019, Dr. Dean co-founded Moral Injury of Healthcare, which is a nonprofit organization focused on addressing moral injury in medicine through technology, ethics, and systems of change. Dr. Dean, thank you so much for joining us today. Take it away whenever you're ready.
Thank you so much. I am so humbled to be part of this conference. I really appreciate the invitation to come and speak with you. And what I'm going to try to do is I'll talk with you